Thank you very much. So again, these are my disclosures. We're talking about the Chiari malformation, and this is an entity, this is pathology that is well known since almost 1.5 century. It was described by Chiari, and we all know that there are different subtypes. Mainly, it's a type of hindbrain abnormality, development abnormality, and the main pathophysiological issue is the alteration in the CSF dynamics. So the most common are the Chiari type 1, Chiari type 2. So we know that Chiari type 1, most of the patients, they have syringomyelia. Most of patients with Chiari type 2 have syringomyelia and also hydrocephalus. But then we know that this is very strange pathology because from time to time, or even more often, we see patients like this one with Chiari 1 malformation, but this patient has hydrocephalus, but then he doesn't have syringomyelia. So sometimes it's difficult to know the pathophysiology and to classify the patients. And also it's not infrequent that some of these patients have some degree of degenerative cervical disease. So the symptoms may be confusion, and even the management of the patient can be difficult. We have some patients like this with more than 1 centimeter descent of the tonsils, but the patient is asymptomatic, completely asymptomatic. So what do we do with these patients? Now the consensus is that symptomatic patients should be treated. There's a lot of debate in how to treat asymptomatic patients, and probably that would be enough for another full session. I know every one of us may have some different opinion, but in general, we know that for symptomatic Chiari 1 and Chiari 2 patients, they should be treated. And the most common surgery for this patient is the posterior fossa decompression. This is the surgery that we usually do. Once we have ruled out other complications, then in the patients we know they don't have any degree of instability, they don't have any basilar invagination, they don't have any hydrocephalus and so forth. And also we know from the last years that in these patients, if we not only do a craniectomy but also an opening of the dura, the relief of the symptoms is more prolonged, and also the degree or the number of patients that present symptoms after some years is going to be lower, and also we have so we have a lower reoperation rate, and we have also better radiological outcomes. But again, here in this pathology, same as many other pathologies, radiological outcomes and clinical outcomes are not always completely correlated. So the technique was described by a group of Spanish surgeons from Barcelona, and mainly it consists on 3 steps. We do a posterior fossa craniectomy, not very big, but wide enough to make a space for the cerebellum. We do a dural opening, trying to preserve the arachnoid layer, and then we have to do, of course, a watertight closure of the dura, and we use some degree of allograft to create artificial cisterna magna. This is the type of surgery we used to do. We also try to do some stitches from the graft into the fascia to prevent the addition of the graft to the arachnoid. We have studies that show us that after this type of surgeries, we have a migration upward of the hindbrain and of the cerebellum, and we have also some studies that show that even in the intraoperative last stages of the surgery, we can do an echography, ultrasound, and we can assure that there's some degree of pulsation of the CSF leak that there was absent before the dural opening. We have a lot of papers with some follow-up, long follow-ups that show that in children and also in adults, the results are very good with a high percentage of resolution and disappearance of the symptoms. And this is one of the biggest series with more than 350 or 370 patients with posterior fossa decompression. And we know that the complication rate is low, and we also know that the degree of morbidity of mortality of this surgery is also low. So this is something that we can offer to these patients. But on the other hand, we also know that at the 5 years follow-up and 10 years follow-up, there are some patients that are going to need a reoperation. That's why some authors have proposed that maybe there are some other issues like degree of instability. The next lecture will be about that. We know that the management of these patients is really very complex because, for example, I can show you this type of patient that we see every day, and this is a patient with a chiari malformation. This is a woman with is a complex to treat because she also is gypsy and she has some social problems, and so the patient complained of neck pain and radicular pain. And as we said, she had a syringomelia, but as we saw in some previous cases, she had also a couple of disc herniations. There's no sign of cranial spinal instability or C1-C2 instability. And so we just performed an ECDF with plating. Obviously, the syringomelia was not modified by this type of surgery, but the patient relieved the symptoms. So we have to think that we really don't know the pathophysiology, and also we can have some concomitant pathologies that can mix or can simulate the symptoms of the chiari malformation. Oldfield is one of the authors that have studied most of these pathologies since the last 30 years. He has done a lot of publications. In fact, this long-term follow-up of 371 patients is his study. And he proposed that the optimal treatment is the least surgery that is safe and eliminates the mechanism underlying the symptom of progression. But our problem with the chiari malformation is which is the mechanism. We have so many different theories. We studied in the university the Water-Hammer-Gardner, the cranial spinal pressure dissociation. This need to have a obex permeability. We now know that most of those patients don't have this permeability in the obex, so obviously this is not the pathophysiology. But we know that there's some degree of malfunctioning in the systolic and diastolic movement of the CSF between the spine and the cranium. And probably when we open this posterior fossa, we restore some way of circulation of this CSF. And we have some studies that prove that after posterior fossa decompression, we have the resolution of the CSF pressures and cranial-spinal compliance, and we have very nice disappearance of the syrinx. But also, we know that in some patients, the syrinx resolution is spontaneous. In some cases, we can explain also this by change in the pressures of the CSF leak. For example, in patients like this, with the kystic fibrosis, in which after the disappearance of the acute phase of the kystic fibrosis and stopping of the coughing, the size of the syrinx and the degree of the lowering of the tonsils get better. But we published 2 different cases in which the resolution of the syrinx was not related with anything that we know. This is a patient that we proposed surgery. The patient didn't want to have surgery, and after 1 year, you see that the syrinx almost disappeared. The patient still had the chiari. This is the second patient. She was diagnosed of chiari and syringomelia because of disc herniation, and she didn't have surgery because of the syringomelia. And after 2 years, you see how the syringomelia disappeared, and we don't know why. So my take-home messages will be that pathophysiology is still not known. We don't know really how it works. That's why we have different treatment options. But probably posterior fossa decompression is a good option in most of symptomatic cases. Thank you very much.